Okay, so this was the title of my presentation. But since submission, we've had to make a minor modification. Well, actually a complete 180, which is a bit embarrassing, but I will, of course, explain why we thought the original conclusions were incorrect. So prior to 2003, trauma-associated coagulopathy was thought to almost exclusively be the result of clotting factor dysfunction from hypothermia and acidosis, factor loss from hemorrhage, and factor dilution from IV fluid administration. And we now know that these are not the initiators of a coagulopathy. Instead, they exacerbate an endogenous coagulopathy that develops early and independently from these factors. And it's been termed acute traumatic coagulopathy, or ATC for short, and also known by a number of other names. And it's found to have developed in around 25 to 30% of severe trauma patients by the time they arrive at hospital. It's characterised by a hypocoagulable, hyperfibrinolytic state. And patients with ATC have around 4 times greater mortality than those without it. And this is independent of injury severity. ATC is also independently associated with other poor outcomes, such as increased transfusion requirements, increased multi-organ failure, and longer hospital and ICU length of stay. There's not been any consensus yet on the diagnostic criteria. It was originally described using the traditional tests of coagulation. However, viscoelastic testing has demonstrated that the primary abnormality in ATC is a reduction in clot strength, which the traditional tests aren't able to detect. So the clot strength is reflected by clot amplitude using ROTEM and TEG. And the clot amplitude at 5 and 10 minutes has been shown to be highly sensitive for the development of ATC. And one suggested diagnostic criteria is a 40% decrease in clot amplitude for baseline, or an amplitude less than 35 millimetres at 5 or 10 minutes. But even with a diagnosis, there are currently no targeted treatments, perhaps with the exception of tranexamic acid. And hampering the development of treatments is a poor understanding of the pathophysiology. But what we do know is that a combination of hyperperfusion and tissue injury are required. But how these go on to cause a coagulopathy is not particularly well understood, although it is thought to involve the protein C system and the endothelial glycocalyx. So the glycocalyx lines the endothelium, and it exists in a constant state of flux depending on environmental stimuli, but in general it's composed of a structural backbone of proteoglycans, predominantly glypican and syndican. Bound to these are 5 different types of glycosaminoglycan side chains, predominantly heparin sulfate, chondroitin sulfate, and hyaluronic. Bound to the endothelium are a variety of glycoproteins. These include the cell adhesion molecules, receptors and intercellular signalling, and receptors involved in coagulation and fibrinolysis, including thrombomodulin. And embedded in the mesh of the glycocalyx are a variety of endothelial and plasma-derived soluble molecules. So the shedding of the glycocalyx following trauma and hemorrhage. The photo on the right is from an electron microscope image of a rat glycocalyx. On the left is normal, and on the right is after 90 minutes of hemorrhagic shock. As you can see, the thickness is significantly reduced, as indicated by the orange arrows there. And in human observational studies, increased levels of syndicin-1, which is highly suggestive of glycocalyx shedding, is associated with increased mortality and the development of ATC. This is, again, independent of injury severity. Increased syndican is also associated with protein C activation. Now, the protein C system itself has been highly implicated in the pathogenesis of ATC. So one hypothesis that links these two together is that trauma causes hyperperfusion, catecholamines, and inflammatory mediators, or some combination of those, cause damage to the endothelium and shedding of the glycocalyx. This releases a number of mediators, including heparin-like molecules, TPA, and soluble thrombomodulin. It also causes increased expression of thrombomodulin on the endothelium. Increased circulating levels of thrombin bind to thrombomodulin and activate protein C. Protein C then goes on to inactivate factors 5 and 8, plasminogen activator inhibitor 1, which leads to hyperfibrinolysis. Now, this is just a theory or a hypothesis based on observational data, so more research is needed. But if it's found that there is a causal link between glycocalyx and ATC, then the glycocalyx is a very promising therapeutic target, as there are a number of substances that are known to repair the glycocalyx, including fresh frozen plasma. So the aim of this study was to establish whether ATC was associated with glycocalyx shedding in an ovine model of ATC. And if such a relationship was found, this would be the first animal model of ATC to demonstrate glycocalyx shedding. There have been a small number of rat models and a pig model that have demonstrated glycocalyx shedding, but none of these developed ATC. And this study will be a precursor, and indeed a necessary first step to future studies that seek to further examine the pathophysiology and to test treatments. So the study was approved by the QUT Animal Ethics Committee. 12 sheep were instrumented, which included being given a general anaesthetic. They were then assigned to one of three groups: a control no injury group, a moderate injury group, and a severe injury group. The moderate injury group received 20% blood volume hemorrhage, bilateral tibial fractures and pulmonary contusions. The severe group received the same injuries with the addition of a hamstring crush injury and had a 30% blood volume hemorrhage. All animals were monitored for 6 hours without intervention before being euthanised. Blood samples were taken periodically for rotum analysis and for measurement of syndicum-1 and HAR-uranon. Now, syndicum-1 and HAR-uranon are both validated methods for detecting glycocalyx shedding. Syndicum-1 is a more popular method, however it's species-specific, and the only sheep-specific assay has never been published before or validated, whereas HAR-uranon is non-species specific, so we were able to use a widely published validated assay. And we've defined ATC development as an XTEM clot amplitude less than 35 millimetres. So by 3 hours post-injury, the XTEM clot amplitude at 10 minutes was significantly lower in the severe group, and by 5 hours post-injury, the severe group had developed ATC. There was no difference between the control and the moderate group. Syndicum-1 levels in the control and the severe group were not different between the control and the severe group over time. In fact, levels actually decreased. This is inconsistent with other studies that have found significant elevations in syndicum-1 post-trauma and hemorrhage. It's unlikely that this was a dilutional effect, as the control group were kept at normovolemia and the severe group didn't receive any fluid resuscitation. It's possible that there was a spike in levels between baseline and 3 hours that we just didn't measure. However, while the kinetics of syndicum-1 aren't very well understood, in human studies, the levels remain markedly elevated for many hours post-injury, so this was unlikely. The most likely explanation was that the unpublished, unvalidated assay wasn't actually measuring syndicum-1. So in order to further explore this, we performed a HAR-uranon assay using a validated assay. And we found that by 3 hours post-injury, HAR-uranon levels were significantly higher in the severe group compared to the other two groups, and that there was no difference between the moderate and the control group. In addition, HAR-uranon levels were inversely correlated with XTEM clot strength, hence the change in the title. So the conclusions that can be drawn from this study are firstly that the severe injury group had developed a coagulopathy by 3 hours post-injury, and that they developed ATC by 5 hours post-injury, and that this was associated with glycocalyx shedding as evidenced by increased HAR-uranon levels, making this the first animal model of ATC to demonstrate glycocalyx shedding. This firstly supports the limited human observational data that ATC is associated with glycocalyx shedding, but perhaps more importantly, it provides a model to further explore the relationship between glycocalyx shedding and ATC, and to test treatments that target the glycocalyx. A limitation of the model is that perhaps 3 to 5 hours post-injury is too long for a good model of ATC. Given that in human population, patients arrive at hospital, well, 30% of patients arrive at hospital with ATC an average of 90 minutes post-injury. Secondly, the sheep-specific syndicum-1 assay probably isn't actually measuring syndicum-1. Now, it's possible that it was, and that the HAR-uranon was elevated for another reason. This is less likely, but in any case, we'll be performing electron microscopy imaging in future studies to definitively answer this question. And we're currently undertaking another study using this model that looks at the effects of the red cell storage lesion on ATC and glycocalyx shedding, and we're currently planning future studies again using the same model. And I'd just like to acknowledge and thank the groups that have funded this study, as well as the rest of the team involved in the study. Thank you.